As Kat said, my name is Joanie. I'm a clinical psychologist and a Sue Stringman Initiative funded PhD fellow. So the topic of my proposal is the co-development and feasibility testing of a prevention intervention for depression or anxiety among undergraduate students in South Africa. So the background to my topic is that mental health conditions are really common among university students internationally as well as in South Africa. So with depression and anxiety being particularly prevalent, so the findings in the table are drawn from South African studies that were done as part of the World Mental Health International College surveys, the South African arm of which is headed up by Professor Jason Beinschies. So these findings show us that 15.4% of students likely met the criteria for major depressive disorder and 10.9% for generalized anxiety disorder in the last 30 days. They also show us that 24.7% of students had met criteria for major depression or likely met criteria, and 22.6% likely met criteria for generalized anxiety in their lifetime. So these findings show us that students are not only experiencing recent symptoms, but they also often have a history of such conditions, which we know increases their vulnerability to future episodes. These conditions have also been shown to have significant implications for South African students. So these include increasing the odds of suicidality and increasing the odds of academic failure. But despite the high prevalence and the serious implications, the treatment rates are low among this population. In South Africa, students mainly have access to public mental health care services and, if available, campus mental health care services. However, we know that public mental health care services are limited, and if campus services are available, these are often overburdened. Additionally, if we look at the mental health intervention spectrum, public healthcare services and campus services generally focus on treatment, which obviously we know it's incredibly important. However, in order to address this large treatment gap or begin to address it in a sustainable way, there also needs to be a focus on prevention of mental health conditions, not only on treatment of conditions. And as we know that it's common for South African university students to experience symptoms but not receive treatment, a more targeted approach, such as an indicated prevention intervention. So this is where individuals are already showing early signs and symptoms, but are not necessarily diagnosed with sort of a full condition. This is probably our ideal intervention point in terms of a prevention approach. So these interventions are becoming more common in high-income countries, but remain quite limited in lower middle-income countries, including in South Africa. There have been studies done in South Africa that have demonstrated the efficacy of certain sort of intervention methods, but these studies have also importantly found that university students have very nuanced perspectives and preferences in terms of how they would like to receive mental health care. So this really presents an opportunity to co-develop an intervention that takes into account context and preferences and perspectives to develop something that is feasible. So this brings me to my study aim, which is to co-develop a contextually relevant and feasible indicated prevention intervention for undergraduate students with symptoms of depression and/or anxiety in the Western Cape. So my study has 4 objectives to meet this aim. So the first objective is to explore components of indicated prevention interventions that have targeted symptoms of depression and/or anxiety among undergraduate students in low and middle income countries. The second objective is to explore the perspectives of South African-based university stakeholders on student mental health challenges, available support, and the potential contextual relevance of certain intervention components. My third objective is to co-develop an indicated prevention intervention that is informed by literature as well as stakeholder input for undergraduate students with these symptoms in South Africa. My fourth objective is to test the feasibility and acceptability of the co-developed intervention from phase 3. So these 4 objectives are going to line up with 4 methodological phases as well as 4 potential publications. So each methodological phase builds onto the next one. So to guide the overall methodology of the study, the Medical Research Council's framework for developing and evaluating complex interventions will be used. So the 4 phases of my study fall under the development and feasibility stages of this MRC model. Additionally, as is consistent with the framework, stakeholder engagement will take place throughout the study. So this will include working with the existing youth development team that is based at CPMH, which does have some prospective university students and registered university students. And potentially to supplement this engagement, a specific university student advisory board might be formed. So my first objective will be achieved through a scoping review. So we've chosen a scoping instead of a systematic review as my aim is to explore and report on different elements of interventions descriptively rather than to assess analytical differences. So a protocol for the review will be developed and reported on in line with guidelines adapted from the PRISMA protocol checklist. And this protocol will also be registered with the Open Science Framework. So to conduct the scoping review, I will use the methodological framework developed by Oxy and O'Malley. The scoping review itself will be reported on according to the PRISMA extension for scoping reviews checklist. So as per stage 1 of the methodological framework, these are my research questions for the scoping review. So the first question is, what indicated prevention interventions aimed at symptoms of depression and or anxiety have been conducted with undergraduates at attending university in low and middle income countries? What evidence-based components were included? So examples of these would be concepts and skills drawn from psychological approaches such as cognitive behavioral therapy, mindfulness-based approaches, acceptance and commitment therapy approaches. Were these interventions developed or adapted for use in their specific context? How were these interventions delivered? So in terms of setting, was it delivered in person or digitally? Format, was it an individual or group intervention? Was it self-guided, like a mobile application? And who facilitated these interventions? Was it a trained mental health professional? Was it a non-specialist health worker? Was it a non-professional, such as a peer-led intervention? And lastly, were these interventions effective, feasible, and acceptable for their contexts? For stage 2, a comprehensive search strategy will be developed through an iterative collaborative approach with my supervisors and a UCT librarian. And the references for the studies identified using the search strategy will be imported into EndNote. So during the study selection stage, the identified studies will be imported from EndNote into Rayon, a program often used for reviews, and then they will be evaluated for inclusion against the following inclusion and exclusion criteria. So this will be done in a 2-step process. The first is the titles and abstracts of the studies are screened for inclusion, and then following that, a full text screening stage will take place. Both these steps will be conducted independently by 2 researchers, and there'll be third-party consultation where there are discrepancies in inclusion decisions. During stage 4, data will be extracted and charted on Excel according to categories that correspond to my research questions. So for example, intervention structure, approach, and delivery specifics. Stage 5 will involve analyzing the charted data and reporting these results descriptively, including numerically and thematically, as well as discussing the implications of the findings. Stage 6 refers to stakeholder consultation. So stakeholders are members of the population who will be impacted on by the research that you're doing. So as the purpose of this scoping review is to map out components of completed interventions in order to subsequently explore if and how they can translate into a South African university context, consultation is going to be a core part of phases 2 and 3 in the study. Which brings me to phase 2. So the objective for my phase 2 will be achieved through an exploratory qualitative study design, and the findings will be reported on according to the core Q checklist. And in terms of study setting, UCT and Stellenbosch University are proposed to be included sites, and we're exploring including the University of Western Cape as well. So these 3 universities are included as and referred to as the setting for my phases 3 and 4 in this proposal as well. So in terms of participants, so two groups of university stakeholders will be included in this phase. The first will be staff members from student wellness or counselling departments, as well as academic staff from various faculties. The second group will be students from various faculties. So in terms of inclusion criteria, staff will need to have had at least 1 year of involvement at one of the included universities. And students will need to be full-time undergraduate students at one of the included universities. They'll need to be at least 18 years of age and comfortable in English. To recruit the staff group, potential participants from student wellness and various faculties will be identified together with my supervisors and my colleagues at CPMH. These individuals will then be approached and invited to participate. For the student stakeholder group, recruitment's likely going to take sort of several pathways. We may approach specific forums and societies directly and invite members to participate. We may also use flyers, which will list the objectives of the study and the inclusion criteria. These will be made available to students through various central points on campus, such as student wellness and various faculties, as well as being disseminated across student communication channels or posted on student forums or social media. These flyers could also be sent directly to students by sort of members of student wellness. So these flyers will contain a study contact number and an email address, as well as a QR code, all of which students could use to make contact to express their interest in participating. As is consistent with a qualitative approach, sample size will only be determined once data saturation is met. However, we anticipate around 20 participants per stakeholder group, and I'll have regular supervision to ensure that a diverse range of stakeholders are recruited. If a larger sample is required for either stakeholder group, snowball techniques will likely be used. In terms of procedures, interviews and or focus groups will be conducted, and these might be in person or online. So whether it's an interview or focus group or online or in person is going to be dependent on the preferences of the participants. And the questions asked will explore topics that are shown there on the screen. So these will include stakeholders' perspectives on the current landscape of student mental health. So in terms of what kinds of challenges do students experience, what kinds of supports are available and accessible to students, what are they actually using, as well as what kinds of supports do they need and what might they prefer. And content covered or questions covered in these focus groups and interviews will also be informed by scoping review findings. So intervention content, such as skills, as well as aspects of delivery, so the setting, format, and facilitation types, as used in other settings, will also be discussed with stakeholders in terms of their perceived feasibility and acceptability in this context. So for data analysis, thematic analysis, as outlined by Braun and Clark, will be used. This consists of 6 steps, as shown on the screen. So for qualitative research, we know that trustworthiness is really important to ensure reliable and rigorous research. So this is going to be promoted in the study in several ways. So 2 researchers are independently going to conduct the analysis, and there's going to be team consultation. I also provide detailed descriptions of context and sampling. I also keep thorough documentation of all study procedures. Also, we're going to allow participants the option to review their transcripts to ensure that how they answered and what they reported was actually what they meant, and also allow them the option of participating in member checking the results to check that these results, the themes that we have identified, feel relatable and feel representative of their experiences. Additionally, reflexivity, meaning to be able to reflect on your own role in your research, so my role in the research and how I engage with the interviews or how I engage with the results, is also incredibly important in qualitative work. And this is going to be practiced through a couple of ways. So I'm going to keep a reflexivity journal throughout. So this is really going to be to critically reflect on my own role, my own positionality throughout all steps of the research process. I'll also have regular supervision, which will include tapping into reflexivity as well. And member checking also contributes to reflexivity to see if my role has influenced how the results have been interpreted and mapped out. So this brings us to phase 3. So the objective of phase 3 is to co-develop the indicated intervention, which includes creating a manualized version of the intervention. So this phase aims to bring together the information gathered in the previous 2 phases, so from the scoping review and the qualitative engagement with stakeholders, to bring these together to make an intervention that's informed by literature and is also informed by stakeholder input, so that we can develop something that is hopefully contextually relevant and appropriate and useful. So to guide the intervention design process, elements of the AHEAD framework will be used. So this framework aims to incorporate strengths from both the human-centered and evidence-based approaches to intervention development through using 2 main formative steps that they refer to as a reviewing evidence phase and a seeking inspiration phase. So in my study, these will be consistent with my phase 1 and 2, so my scoping review and my qualitative engagement with stakeholders. So for phase 3, we'll be drawing on the following steps of the framework. So these include synthesizing, developing guiding principles, and the ideation step, which involves an iterative process of brainstorming, prototyping, and testing. So I'm going to describe these in a bit more detail under procedures. So these steps will be used to develop and refine 3 working versions of the intervention and the intervention manual. So the intervention will initially be drafted by mental health intervention specialists that are associated with the CPMH, together with the relevant advisory boards that I mentioned earlier. The participants are going to be involved in adapting and refining this draft to create a version 2 and 3 of the intervention. So the participants are going to be wellness staff, and they're going to be wellness staff members who are providing care, and students from various faculties. So the same inclusion criteria as used in phase 2 will be used for both groups. However, for the student participants, there are going to be 3 additional criteria which will be included. So these include that students will need to screen they'll need to screen at risk for potential depression and or anxiety by obtaining a score of 10 or higher on the Patient Health Questionnaire 9 or on the Generalized Anxiety Disorder 7-item scale. And additionally, receiving ongoing counseling is also going to be an exclusion criterion. So this doesn't refer to pharmacotherapy, but this refers to ongoing psychological treatment, as well as if a participant or prospective participant is actively suicidal, they will also not be eligible for inclusion. So the same recruitment pathways as used in phase 2 are going to be used. We will approach specific individuals, we will use flyers, and we will potentially also use snowball techniques. And attempts will also be made to recruit participants who vary in age and gender. Okay, so as stated earlier, the displayed steps from the AHEAD framework will be used to guide the intervention development procedures that are used in this phase. So to draft the initial intervention, referred to as version 1, several workshops will take place, which will involve a process of synthesizing. So this is the process of drawing together and integrating the findings and themes from both formative phases. And based on the integrated findings, guiding principles will be established. These are key values that will be prioritized and used to guide the intervention development. So examples of such key values or principles can be things like needing the intervention to be accessible, flexible, low burden. So based on the synthesized findings and these key principles, key aspects of intervention content and delivery will be brainstormed. So these engagements, these workshops will continue until a cohesive version 1 of the intervention has been drafted. Following this, the draft will be further refined with around 6 students and 3 wellness staff members. This will involve conducting separate workshops where each group will be exposed to and give feedback on prototypes, which means the rough drafts of the brainstormed components. Through their input, refinements, and adaptations to the intervention content and delivery processes will be made. The cycle of prototyping and refinement will likely be repeated over multiple workshops until a version 2 of the intervention is finalized. Next, the working intervention will be tested with the target population. While the specifics of the intervention delivery are only going to be confirmed during this phase, so for example, whether it's an individual or group intervention, how long the intervention is, we anticipate that this testing will be done with around 36 students, potentially 12 from each university. I will deliver the intervention, most likely with one trained co-facilitator. The feedback obtained from participants throughout the testing will be integrated and appropriate refinements made, which resulting in version 3. So this brings us to phase 4. So the objective of this phase is to test the feasibility and acceptability of the co-developed intervention among the target population. So a mixed methods approach will be used, which will consist of an individually randomized 2-arm feasibility trial with embedded qualitative interviews. So feasibility studies are really essential in identifying and refining issues related to an intervention. These studies also inform whether a full evaluation and implementation of an intervention is feasible or recommended. The protocol and trial will be guided by and reported on following established guidelines shown on the screen, including SPIRT and consort standards. So we aim to recruit 120 students into this trial. The inclusion and exclusion criteria will be the same as for phase 3, except there'll be one additional exclusion criterion, which is having participated in any prior research activity, so phase 2 or phase 3. Convenience sampling will be used, and the same recruitment pathways as used in phase 2 and 3 will be employed, so approaching specific members and distributing flyers and potentially snowball techniques. And again, our efforts will be made to recruit participants who vary in age and gender, because we know that they tend to be also quite female skewed. So in terms of procedures, if a participant is eligible and they're willing and they've completed informed consent procedures, they will complete a baseline assessment and then they will be enrolled in the study. The baseline assessment will be done by a REDCap, and it will take place in person with the student using a tablet device to complete the survey independently. Following baseline completion, randomization will occur via REDCap using a 1-to-1 ratio. As this is a feasibility study, a sample size calculation was not conducted. However, based on recommendations and recent feasibility trials, we're going to aim to recruit 60 participants to the intervention arm and 60 to the control arm. The particulars of the intervention and control arm are going to be confirmed during phase 3. However, the control arm will likely receive a single psychoeducational session and a resource list. Follow-up assessments will be completed post-intervention and again at a 3-month follow-up point. And the same as for baseline, these will be completed independently in person. So therefore, any blinding of research assistants conducting these follow-ups will not be necessary. Additionally, facilitators and a random selection of participants from the intervention arm will be approached post-intervention and invited to participate in an interview about their experiences. And the same as for phase 2, sample size for qualitative interviews will be determined upon data saturation. However, we anticipate around 20 for the participant group. So prior to the implementation of phase 4, as project leader and a clinical psychologist, I will lead the training of the employed facilitators. And while we don't yet know the specifics of the intervention, and these will only be finalized in phase 3, in line with the task sharing approach and the fact that this is an indicated prevention intervention, there's a high likelihood that the facilitators will not be trained mental health specialists. So therefore, the training will cover both core therapeutic and intervention-specific competencies. I'll also provide the facilitators with weekly supervision throughout the intervention. Detailed notes and logs of these supervision sessions will be kept. So as feasibility and acceptability are the main focus of this study, of this phase rather, these are the main outcomes that will be assessed. So we'll be using a number of indicators, including quantitative and qualitative indicators, to measure feasibility and acceptability. So indicators related specifically to recruitment and study procedures are shown here on the screen. So we've specified specific progression criteria to measure the feasibility of each quantitative indicator. So this helps us identify what aspects of the intervention worked, what aspects did not work, which is important for us to know if we were to move forward after the feasibility with their full implementation. But it's also important for other people to know who are going to be designing studies for a similar context, so they understand what might work and what might not work. So we've defined these progression criteria using what's referred to as a traffic light system. So if we look at the screening and enrollment indicator, if we recruit at least 5 participants per week, this will be in the green zone. So this means that this aspect of recruitment, screening, and enrollment is deemed feasible without any modification. If we recruit between 3 and 4, this falls in the amber zone. I don't actually know if zone is the right term, but that's what I'm going with, in the amber zone, which means that we likely need a little bit of modification to say that this is feasible. If it falls in this red zone, if we recruit 2 or less per week, this means that we need to go back to the drawing board and think about why it's not as feasible as we would have liked it to be. Okay. Yeah, all right. So this slide shows indicators related to the feasibility and acceptability of the intervention. So this includes facilitated competencies. So therapeutic competencies will be assessed using the ENACT SA tool, and intervention-specific competencies will be assessed using a pre-developed checklist. And then there are the traffic light criteria. So in addition to socio-demographic and university-related variables, we plan to include the following as secondary psychosocial measures, which will be repeated at each assessment point. So baseline, post-intervention, and 3-month follow-up. So these are the PHQ-9, the GAD-7, and then 2 emotion regulation tools, the ERQ and the DERS-16, as well as the ASSIST version 3 to assess substance use. So these outcomes are secondary to the feasibility ones and are being included as they may allow for investigating their feasibility as well as for collecting some preliminary data. But this will just be for exploration, as we will not be statistically powered to do more definitive analyses. For both feasibility and secondary psychosocial measures, quantitative analyses will be conducted using SPSS. For the feasibility indicators, descriptive analyses will be used. For the secondary psychosocial measures, descriptive and inferential analyses will be conducted. For the qualitative analysis, thematic analysis as described under phase 2 will be used. Okay, in terms of ethical consideration, so ethical approval for all 4 phases will be sought from the Human Research Ethics Committee at the Faculty of Health Sciences at UCT. Participants will only be enrolled in phases 2, 3, or 4 once they've given informed consent. So all prospective participants will be taken through the relevant information sheet and consent forms and be given the opportunity to ask questions. Information forms are going to include all key information as listed on the screen. In terms of risk, there'll be an established standard operating procedure for assessing and managing distressed and suicidal participants. The training that team members are going to receive will include how to implement this SOP. Any adverse events and referrals will be logged and discussed during supervision, which I will lead as project leader and a clinical psychologist. The research team and procedures involved will all adhere to the POPI Act, and data will be managed and stored according to UCT guidelines. I feel like that went really quickly, but a big thank you to my funder, the Sue Stringman Initiative, as well as to my supervisors, Professor Catherine Sorsdale, Associate Professor Claire van der Westhuizen, and Associate Professor Jason Weincheese. And thank you for everyone who has attended. I hope you're all still there.
Thank you so much, Joanie, for that very clear and well-formulated presentation. Thank you very much. If you could stop sharing your screen, I'll hopefully be able to see our other reviewers. So we're going to move to phase 2. So with so many phases in these studies, we're going to move to phase 2 of our engagement. So I am going to ask Devika Gupta. I'm going to introduce you first before I hand over to you. But thank you so much for being willing to join us today. So Devika is a postdoctoral research fellow at the London School of Hygiene and Tropical Medicine based out of Sangha, a community-based mental health organization in Western India. She has previously led teams to develop and evaluate psychosocial interventions for adolescent depression and anxiety, mental health problems among women survivors of domestic violence, and mental health problems in hard-to-reach populations. So I think you're very well placed to provide some guidance for Joanie. So let me hand over to you.
Thank you so much for that kind introduction, and well done, Joanie, for that presentation. I think what you're proposing to do is certainly ambitious, but super important and really interesting. So thank you so much for putting in the effort. I've got a couple of questions and comments. I'm going to try and ask maybe two, and then we'll see if we don't have time, I can send them over to you, for you to think about later. So my first question is about some of, I think, phase one, the transition from phase one to phase two of your proposal. Since you've mentioned that it's a scoping review, it is possible that you might end up with quite a few components and interventions on your hands. And so how do you expect to identify or transform these intervention components into materials that you can take to your interviewees and in the focus group discussions? Like, what if you end up with too many things? How do you plan to shortlist or manage and elicit sort of, input from your primary data participants in order to move these components along into the later phases?
Yeah, that's a really good question. It's quite difficult because we don't, because the one phase builds on the other, we don't yet know what we're going to find. So it's hard to know exactly what that phase two is going to look like. I guess we're going to have to, I think that there will be lots of overlap in terms of what different studies have done when we map out the different components. And I guess in terms of prioritizing what will be presented to stakeholders in phase two, my feeling would also be to look at which ones were found to be effective in contexts that are likely to be, I guess, most similar to our context, and probably prioritize those ones. And then present them to, and I guess what's nice about phase two is that the idea is that we will be including participants who have sort of some knowledge, or they're immersed in their sort of context and they've got some knowledge of sort of mental health. So I guess in terms of them understanding what I'm asking, I'm hoping that wouldn't be an issue. But yeah, in terms of prioritizing which components, I would imagine the ones that have been found to be effective in contexts most similar. I'm not sure if that answers the question.
It does answer the question. And I think that's maybe something you could think a little bit about, is that do you need to add a mini step in this transition between phase one and two, just in case you end up with too many different things, and you have to think about how we can present these in a consumer easy to understand and respond way for your participants in phase two, right? Thank you for that answer. My next question is about the intervention development stage. I'm very curious about your rationale for excluding participants who are receiving counseling. And I'll maybe tell you a little bit why. If you're developing an intervention for participants who need an intervention, then why are you excluding those who are receiving another kind of intervention?
Yeah, it's actually a very good question. And I guess the rationale, was because we wanted it to be a similar population to what who's going to be receiving the intervention in phase four. But yeah, it is a very good, and I think what I had at a different point, which maybe I should consider going back to, was because in that procedure part for phase three, I talk about these different versions. And for the version two, which was, I think, going to be around 6 students, I was originally thinking that group, potentially that shouldn't be an inclusion criteria, that group, it doesn't matter if they are receiving, or actually potentially, as you're saying, it could really be helpful. And then I think for the version 3 in phase 3, so complicated, I think that it is helpful that they aren't receiving, because then sort of like you're taking something that's been developed and seeing. But yeah, it's a very good question, and I think I should think about putting that back in as not an intervention, not as an inclusion criteria for that version 2 group, because they'll be able to bring valuable input through that. Thank you for that.
Yeah, I'll stop for the moment. Yeah. Thank you for your answer. Yeah.
Thank you very much. All right, I'm going to ask Professor Xanthi Hunt if she's here. There we are.
I am.
Oh, there you are, in the middle of my screen. So welcome and thanks again for joining us. So many of you from South Africa will probably already know Professor Xanthi Hunt. She's a mental health lead at the Africa Health Research Institute, AHRI. There's always so many acronyms, where she leads a program of work on adolescent mental health. Her research sits at the intersection of adolescent mental health, disability, and violence prevention, with the focus on understanding the social determinants of young people's functioning and health, and the potential of digital innovations to meet mental health challenges. So I think you're also really in a wonderful place to really provide valuable insights into Joanie's proposal. So over to you.
Thank you. I just wanted to say, Joanie, I really enjoyed reading the proposal. It's really well structured. It's clear, it's comprehensive, and I think it's a very well thought out study. And so I think in terms of the technical aspects of the piece of work, it's really solid. I think I want to raise maybe two sort of issues that require like a little bit of a toggle back, and I don't think that they need to unsettle the whole intention of what you're going to do. I think it might be it's something that you want to think about in terms of framing, but maybe there are also seeds that you can just think about in terms of if there is room to rejig a couple of things. So the first is around the existence of the work in the Western Cape. So I've done university work and I've done it in the Western Cape, and I always battled a little bit because a lot of the motivation that we use is around low and middle income countries. So we speak about the burden in low and middle income countries, we speak about poverty, we speak about language and complexity, and then we work with students in Stellenbosch.
Yeah.
And that's not to say students at Stellenbosch don't need mental health intervention. They absolutely, absolutely do. And we've seen that, and there's data to support that. But some of the rationale for intervening with university students is a little bit different, and has a kind of human capital agenda aspect to it that isn't easily extrapolated to other LMIC type public health language. So at the like extreme end of my encouragement would be, can you try and expand to a site that's outside of the Western Cape? But the maybe softer end of it would be if you have any thoughts about how you could couch the language and the motivation in one that doesn't make the setting a limitation.
Yeah, that's a really, really great point. And I think that that's also what's so interesting about South Africa, because if you're looking at results from university students in Gauteng, you're looking at quite a different profile to what you're looking at university students in the Western Cape, and also between universities as well, obviously from what we know from the National Student Survey as well. I think that's a very interesting point. And like you said, it's a very specific group of people that it's not necessarily going to line up exactly with what we're thinking when we talk about lower middle income countries, which I also think is possibly comes through in also some of the risk factors. And what I'm also quite interested to find out in the phase 2 as well is what's contributing to distress for university students, likely potentially quite different from what contributes to distress in other populations. So I'm imagining things like that pressure, that academic pressure, but also the pressure of what it means to be at university and what that means for your prospects, and what that means for the prospects of your family and things like that. And I think it's a very good point of thinking about outside of the Western Cape. As you were speaking, I was also thinking about sort of not just I guess the university, but there's also a lot of other higher education settings, which are sort of colleges, not necessarily universities, which could also be an interesting thing to think about. Yeah, so thank you.
Cool. And yeah, I mean, I understand that often the scope of projects is determined by a variety of other factors, but just something to kind of flag and think about. And then the other is, I suppose, with a lot of particularly kind of manualized CBT interventions, there are a lot of them. And so I wondered if one of the things that maybe didn't come through so much in the proposal or in your presentation that you could speak to is how you situate the need for this particular intervention versus what already exists.
Yeah, I did struggle to figure out how to phrase, I guess, that. I think part of what potentially sets it aside is the idea that it's co-developed, so that it's developed together with university students. I think a lot of the work that I've read from South Africa, and also when I found out you were going to be a reviewer, it was quite exciting because I read your name a lot on these studies. But you know, there's quite a lot of great studies that have looked into feasibility sort of separately. So I've asked, you know, students, what are your opinions of online interventions, for example? What are your opinions about this, or your attitudes towards that? Would you be willing? So we have that data, and then we also have you know, sort of intervention data, and then quite a lot of data that's happened after intervention. So like, what did you enjoy? What were your opinions and your preferences? And I think from my perspective, what maybe sets mine aside is the idea that we're almost, and obviously students are not going to know how they experience the intervention until they go through it, but the idea that we're almost asking beforehand, like we're sort of linking those two. So we're asking specifically about this, not a theoretical intervention, but we're designing an intervention and adapting it according to preferences and opinions as we go, and then testing it. So not just getting theoretical perspectives and then perspectives or opinions after the fact. I don't know if that makes sense.
Yeah. Absolutely. And I think that's something that if I were you, I would then kind of amplify and not sell, but really highlight as kind of a central thing, because I think it's true. And the more that you can kind of elevate and explain how the co-creation is going to be really meaningful. I think you had some great sections on it. But also to highlight that when you have those large kind of groups and wrangling people, that the priorities of people's lived experience might also not align with what's in the theory or kind of what the people say. So also to have some thinking ahead of the time about if students come back and are like, no, we'd like money. And then you're like, but I'm building a CBT thing. So just to think a little bit also about the co-creation. But yeah, I would amplify that because I think it's a strong aspect here. I'm going to pause and also maybe shuttle back to Kat if Davika wants to take some more.
Davika, did you want to add anything there, or are we?
Yes, just because, thank you, just because Dr. Hunt brought up co-development, I think that maybe, Joan, you can spend a little bit more time in figuring out the co-development aspect. I think just pushing the envelope a little bit, because in the way that you described it in the presentation, it seems a little bit, it's like a feedback loop, right? Which is not necessarily where the principles of co-development or participatory development lie, right? It's a little bit more about overturning the power structures between intervention developer and intervention recipient, right? So if it's something that, like exactly what Dr. Hunt said, if someone comes to you and says, this is all really nice, but it would be amazing if you could give me some cash to, that could help me because I'm like going through an employment, I need money, right? And that's what's causing me a lot of anxiety. So I think, I think examining whether or not there is openness for that sort of thing, and then rephrasing how you're approaching co-development, whether that means not calling it co-development or whether that means, pushing how much power and agency the young people with lived experience that are involved in the intervention development will actually have to, disagree with you or propose what they really want. Versus what the literature has said that helps them and they should want. So I think that's something that I would think a little bit more about.
Yeah, definitely. Yeah, thank you. And I think maybe something I didn't speak to is, I did for phase 2, the online, the focus groups. If I do focus groups, if there's enough interest from participants, it is, my plan is for it to be students in their own group and staff in their own group, so that there aren't sort of those kinds of power structures. and also in the co-development as well. I think with using the staff members there, it's more going to be the co-development is actually going to be with the students, and then we sort of almost running it by the staff and going, is this something that you've done or that you are doing with students? And then they say yes, and it actually doesn't work. Or yeah, but I think that's definitely a very important point. So thank you for that.
Good. And maybe we could just, a bit of context here is that Joanie's in a very lucky position, a fortunate position, that there's quite a lot of funding for her project. So she's funded by the Sue Struman Initiative, which means we're not kind of stuck on, oh, it must be face-to-face or it must be individual. It might be that maybe a bit's face-to-face, maybe it's a bit in group, maybe there's ecotherapy, maybe some is digital. So I think she's in a nice position to not feel like we're stuck, not stuck, but restrained. And I think what's also nice is that we always know that sort of co-creation process, in our experience, it takes so long. It's much longer than we always anticipate. And Joanie, you put a nice piece in your timeline where you can really do this properly. So I think it's really exciting. So can I open to the floor? Does anybody have any questions, any comments for Joanie at this stage?
Hi, Cass, it's Bron. Hi. Can you hear me?
Oh, yes, we can hear you now, Brahman. Thanks.
Hi, Joanie. Well done. I just have one question, and that is for phase 2. Why you may not want to, or you've perhaps argued this in your proposal. Of course, I haven't read that. And in terms of stakeholder perspectives, what about parents? I mean, these are undergraduate students. They're transitioning from high school into university. This is an intervention focused on prevention. For many of them, the core source of support would be parents, or the core source of anguish. I mean, it could go either way. But I wondered about understanding the perspectives of parents as well, just adding that in and seeing what comes up. I mean, perhaps for the other phases, it may or may not be necessary, but I think in understanding those challenges and needs and relationships with parents, if anything might come up. There's pressure to perform, academic, hearing it from the other side too, what's in place, I think could be really valuable.
Thank you, Brendan. Yeah, I definitely think that's actually something very important to consider, because also something it does, although there's not a lot of literature in terms of family sort of involvement and pressures, but definitely what has come through is that from what has been done in South Africa, it sort of shows that the familial relationships are really important, as well as the peer relationships, whereas internationally, peer relationships at university level seem to almost be more important. But for South African students, it seems there's the family ties are very strong. So it's a very good point. Yeah, thank you.
Right, wonderful. John, I see you were next. Over to you.
Thank you very much for giving me a chance. Very nice presentation. I would be very happy to see the results because Kathy knows me. I'm an education psychologist, and most of my studies I do among learners, undergraduates, and the adolescents in secondary schools. So based on the project is very good. And now in Malawi, we want to do a study among postgraduate students to see the psychosocial problems. And definitely based on what you are going to observe in South, maybe can help us how to design how we can do the intervention in Malawi. But otherwise, I looked at the abstract. It's a very, very good idea. I was like, wow, we will be very ready to hear the results from South. Otherwise, all the best from Malawi. Thank you.
Oh, thank you so much. It's really kind. And yeah, I would love to. It sounds lovely. Thank you.
Thank you, John. And now over to you, Simone. Your hand was next.
Thanks. Joanie, what a fabulous project. I agree, it's extremely ambitious and but very important. I'm just wondering, even though they're secondary outcomes and you're only conducting a feasibility trial, whether once you are assessing for MDD and GAD, whether it might be worth looking also at PTSD symptoms, given the chronic trauma in our society. I may have missed it, but I think you are assessing for substance use. Yeah. Okay, so that was just a small point to consider. And you may find that if there, I mean, I think there, I'm not too sure what the data is on from the other studies that have been done on prevalence of mental health conditions among South African students, but a kind of trauma-informed approach to intervention design, and looking, and potentially in your reviewing, looking at trauma, particularly adding terms that might explore trauma-informed interventions might be useful.
Yeah, thank you, Simone. Yeah, definitely. I mean, trauma is something that I think, and actually it links a little bit maybe with what Xanthi was saying. I think that's something that does sort of, you know, even though we're looking at university students, which maybe is different from our sort of typical South African population, trauma is sort of the thing that, or one of the things that seems to be a pervasive thing, and definitely from what my risk factors definitely stands apart from the other risk factors in other countries. So yeah, it's definitely something to consider. It's an important point. Yeah, thank you.
Thanks, Simone. To Xanthi.
Oh, Xanthi, sorry, on mute.
That happens. I had one additional question, which was just, I think, to the other points about the potential exclusion of people who are in therapy. You mentioned that people with suicidal ideation will be excluded. Is that correct?
So not suicidal ideation, sort of high risk suicide. So we call actively suicidal. Yeah. So not ideation, because that will be a big
chunk.
Yeah.
Okay, cool. Thank you for clarifying.
Thank you. Any other questions or comments for Joanie? You've been very efficient today. Yeah, not missing any WhatsApps or any messages. Great. Well, I think if we are done there, I think we can. Oh, there might be one. We're all good. I think if we are done, we will not continue. But just want to say thank you so much to the reviewers, and Joanie, congratulations. I hope you go and celebrate in the next 2 minutes when I see you. And thanks just to everyone who is here today and supporting Joanie in the center. Thank you, everyone.
Thank you. Thanks, everybody. Bye.
Thank you. Bye-bye.
Bye.
Bye. Bye.
Bye.
Well, thank you.